Hi, I'm Greg Wilde. I'm a musculoskeletal radiologist with a special interest in musculoskeletal ultrasound. Welcome to the Pegasus Lectures Upper Extremity Nerve Anatomy and Pathology module. I have no financial disclosures relevant to this presentation. So let's look at the structure of nerves, starting with the microscopic level. So we start off with an axon where nerve signals are propagated. And then this is surrounded by a myelin sheath. So it's a myelin sheath. So we call this a myelinated axon. So each myelinated axon is incorporated into the larger nerve fascicle. Between the axons are the endoneurium. So the endoneurium is the connective tissue holding all the axons together. So all of these axons combine and form a nerve fascicle. Between the fascicles is more endoneurium connective tissue, and then there's a perineurium that surrounds each fascicle. So perineurium, and then more connective tissue between each fascicle. And then a group of fascicles together form the peripheral nerve, and the full peripheral nerve is surrounded by epineurium. So endoneurium surrounding axons, perineurium surrounding the fascicles, and then the epineurium surrounding the peripheral nerve. What we actually see on ultrasound are these individual fascicles with the surrounding connective tissue, and it creates what's coined a bag of grapes appearance, where each grape is an individual nerve fascicle, and the space between the grapes is the connective tissue. Nerve pathology is typically caused by entrapment at sites of compression, so anatomic tunnels where if there's a mass or something else that causes the nerve to be compressed within the tunnel, or compression by a mass adjacent to the nerve. When nerves are compressed, they become swollen and hypoechoic, sometimes with increased vascularity, just proximal to the site of entrapment. Typically within the site of entrapment, so within the tunnel, there's a focal decrease in caliber of the nerve. There was a list of normal nerve cross-sectional areas at anatomic sites throughout the body, compiled by Francis Walker. And so this table of normative values is useful for comparing the nerve size at these sites in pathology to compare where what the normal size should be. And the other thing that you can do to determine if a nerve is enlarged is you can compare the nerve site at the site of enlargement to a site where you know that the caliber should always be normal. You can also always compare the nerve size within the area of compression where there's enlargement of the nerve to the opposite extremity of the body. Nerves can also be affected by primary neural tumors that can cause swelling. So nerves enlarge when they get compressed, but you can also have nerve enlargement when there's a primary tumor. So this is the table of normative values. This is going to be available to you to access, to look at individual values and use it as a reference separately from this lecture. But the table basically has each nerve and then the site along each nerve where normative values have been obtained. And then for each site, so for example, we were interested in the size, whether the size of the median nerve in our particular patient is abnormal. So we can look at what the mean of normal is in square centimeters, the standard deviation, and then a reference range based upon 2 standard deviations from the mean in either direction. So if you have a value that's less than 0.005 and greater than 0.15, that would be beyond the reference range. And then they also did measurements to see what the normal side-to-side difference in asymptomatic patients were. So you can also use that if you get a measurement on the opposite side. If the difference between the sides is greater than this difference, then you can presume that the nerve is abnormal. So let's talk about the upper limb nerves now. So first, the sensory innervation of the upper limb. So we have the supraclavicular nerve innervating this area of the shoulder. We're not going to be covering that nerve. The axillary nerve covers this region over the deltoid muscle. Then we have the, this is the posterior view here. So the radial nerve covers the posterior aspect of the upper arm, the posterior elbow, and then the posterior forearm going to the thumb, the index finger, the middle finger, and then the radial half of the ring finger. And then you'll notice that the ulnar nerve covers the innervation of the small finger and the ulnar half of the ring finger, both posteriorly and anteriorly. The musculocutaneous nerve covers the sensory innervation for the lateral forearm. So that's this here, both anteriorly and posteriorly. Moving to the anterior side, you can see that the median antebrachial cutaneous nerve provides sensory innervation to the medial half of the arm. We're not going to be covering that nerve. And then the median nerve, importantly, provides innervation to the palmar aspect of the thumb, the index finger, the middle finger, and the radial half of the ring finger. So this distribution is important for diagnosing carpal tunnel syndrome for the median nerve, and then cubital tunnel syndrome for the ulnar nerve, and then for compressions of the superficial branch of the radial nerve, the symptoms would be limited to the dorsal side of the thumb through ring fingers. So first, let's look at the suprascapular nerve. This represents comes from the upper trunk of the brachial plexus. It travels beneath the suprascapular notch. So branches from the brachial plexus, upper trunk, then comes down beneath the superior transverse scapular ligament within the suprascapular notch. It gives off two branches to the supraspinatus muscle, and then it passes through what's called the spinoglenoid notch to give branches to the infraspinatus. So that anatomy is important to understand, and you'll see why in a second. So if you entrap the nerve at the suprascapular notch, so this location right here, then you're going to cause problems within both the supraspinatus and the infraspinatus muscle. So you'll have denervation in both of those muscles. If instead you entrap the nerve at the spinoglenoid notch, then you'll have symptoms only limited to the infraspinatus muscle, because at this point the branches to the supraspinatus have already gone to the supraspinatus. So to make a diagnosis of denervation, you look for atrophy of the supraspinatus and/or infraspinatus muscles, and based upon whether both muscles are affected or just the infraspinatus, you can have an idea of where the impingement might be, and you can look for the any abnormality causing the impingement. So this is the suprascapular nerve within the suprascapular notch beneath the supraspinatus muscle. Most larger patients, you can't see it that well because it is very deep, but you can definitely see if there's any mass in the suprascapular notch that might be compressing the nerve. And then you also look for any atrophy of the supraspinatus muscle. And we can follow the nerve. This is a long axis view of the nerve in the suprascapular notch. And we can follow the nerve down to the spinoglenoid notch. So this is the spinoglenoid notch here. It's this region of the posterior to the glenoid. And this region can be affected because the posterior labrum is right here. If there's a paralabral cyst from the posterior labrum that travels into the spinoglenoid notch, you can get compression of the suprascapular nerve with resultant denervation of the infraspinatus muscle. So there are multiple causes of entrapment of the suprascapular nerve. These include stretching of the suprascapular ligament or ossification. Fractures of the scapula can impinge the nerve. Overhead activities such as in painters, electricians, or volleyball and tennis players, which cause a chronic mechanical stretching of the suprascapular nerve. You can see denervation problems, surgical injury, soft tissue masses, tumors, vascular malformations, and then, like I mentioned before, ganglion cysts at the spinal glenoid notch, and you can have them at the suprascapular notch associated with labral tears. So now the axillary nerve, this originates from the posterior cord of the brachial plexus with the radial nerve. It courses within what's called the quadrilateral space, comes out of the quadrilateral space, and it provides innervation to the teres minor muscle and then the deltoid muscle. The borders of the quadrilateral space are above the teres minor muscle, below the teres major muscle, so I'm drawing the boundaries for you, then medially the long head of the triceps muscle, and then laterally the surgical neck of the humerus. So it's this quadrilateral spaced area where the axillary nerve comes out, which is called the quadrilateral space. In quadrilateral space syndrome, the axillary nerve becomes compressed or stretched as it goes through the quadrilateral space. The most common cause of quadrilateral space syndrome are what are thought to be fibrous bands, which can only be identified at surgery and are not visible with imaging. You can have mass lesions such as a very large paralabral cyst that extends down from the glenoid to the axillary nerve, but that's uncommon. The common finding that you will see is atrophy of the teres minor muscle without atrophy of the remainder of the rotator cuff. And then sometimes you can also see atrophy of the deltoid muscle in conjunction with the teres minor muscle atrophy, but it's much more common just to see atrophy limited to the teres minor, and that you should suggest that it's quadrilateral space syndrome in that case. So this is, we were able to actually see the axillary nerve in this patient. In most patients it's difficult to find, but it basically courses posterior to the humeral neck. If we look back at the graphic, you can see that the axillary nerve, you can find it as it comes around the humeral neck, and then right before it divides to go to the deltoid and the teres minor. So here we were able to find it along the humeral neck at the level of the teres minor. And this is what teres minor muscle atrophy will look like. So we have a very echogenic muscle with volume loss, so it's narrower than this normal teres minor muscle on this side. Now let's look at the median, radial, and ulnar nerves in the arm. So all of these represent the terminal branches of the brachial plexus. The ulnar nerve we'll look at first. So the ulnar nerve travels through the arm, and it's going to run posteriorly to the medial epicondyle through the cubital tunnel, and we'll cover that a little bit later. And then the median nerve is going to run through the antebrachial fossa with multiple potential sites of compression as it runs through this region of the elbow. Then the radial nerve is in the arm. We're going to show it on the next slide, but it wraps around the posterior arm and then comes anterior to the lateral elbow, and then it divides into the superficial branch and the posterior interosseous nerve. And we'll go through that in detail in a minute. So here's the image of the radial nerve wrapping around the posterior humerus. The radial nerve can become injured because of its intimate relationship with the spiral groove of the humerus. So humerus fractures in this region, any kind of surgery or trauma can injure the radial nerve as it crosses through the spiral groove. And then remember, it runs anterior to the lateral epicondyle to emerge anterior to the radiocapitellar joint. So here's an image of the radial nerve within the spiral groove. So we found it in this patient in that location. No abnormality here. This was a patient who had palsy in the, so sensory deficit in the posterior aspect of the thumb through ring finger. So like we talked about, the sensory innervation of the radial nerve, and also weakness in the extensor muscles. So in this patient, we found a radial nerve in the spiral groove that was enlarged, and she had had an injury to the radial nerve in that location. And here's the comparison to the opposite side. So just like imaging, all nerves, you follow them, and then if you see an area of decreased echogenicity or enlargement, you can compare it to the opposite side, and also compare it to the table of normative values. So now the ulnar nerve we'll focus on a little bit more closely. It runs posterior to the medial epicondyle, deep to the cubital tunnel retinaculum within the cubital tunnel. So here's the transverse images. So you have the medial collateral ligament posterior bundle forming the floor of the cubital tunnel, the olecranon forming one side wall, the medial epicondyle forming another wall, and then the cubital tunnel retinaculum, or also called the arcuate ligament, running superficial to the ulnar nerve. The ulnar nerve then enters the forearm between the two heads of the flexor carpi ulnaris muscle. So this is an enlargement of the graphics, just giving you a little bit more detail, showing the two heads of the flexor carpi ulnaris, the ulnar nerve running posterior to the medial epicondyle, and the boundaries of the cubital tunnel that I described on the previous slide. These are images of the ulnar nerve in the axial plane. So we're at the medial epicondyle. This is the ulnar nerve here. It's superficial in this location, so it's very easy to find and see. So we measure the cross-sectional area, and then we, in our typical exam, we'll then follow it into the cubital tunnel, measure the cross-sectional area within the cubital tunnel. Notice the arcuate ligament superficial to the ulnar nerve, and then the boundaries that we described before, the olecranon and the medial epicondyle. So that's how you know that you're in the cubital tunnel. In this case, there's no difference in the size between the ulnar nerve on this slide, 0.05 square centimeters, and the ulnar nerve on this slide at the medial epicondyle. So this is a normal ulnar nerve. And then we have here demonstrating the two heads of the flexor carpi ulnaris. So this is one of the heads here. Here's the nerve between the two heads, and here's the other head here. And then as part of the examination, we always assess for ulnar nerve instability, which I'll talk about in a minute further. What we have the patient do is, while we're imaging, have the patient flex their elbow all the way to maximum flexion, and just see if we see any instability of the ulnar nerve, which in this case there was not. So cubital tunnel syndrome is can be caused by decreases in the volume of the cubital tunnel. At 90 degrees of elbow flexion, the arcuate ligament is tightest, and what can also contribute to it is ulnar collateral ligament and triceps medial head bulging. The cubital tunnel is also reduced in size during elbow flexion because the arcuate ligament becomes progressively taut. You can see ulnar nerve subluxation in up to 16% of asymptomatic individuals. So the presence of ulnar nerve subluxation does not mean that there's ulnar neuropathy. But when patients have symptoms referable to the ulnar nerve, then the subluxation can be meaningful, and you should look for causes of cubital tunnel syndrome. Athletes can get cubital tunnel syndrome because of lateral shift of the ulna caused by chronic laxity of the ulnar collateral ligament. Extrinsic causes of compression can also cause cubital tunnel syndrome, so tumors, distended bursae, ganglions, loose bodies, osteophytes, the anconeus epitrochlearis muscle, an accessory muscle in the cubital tunnel, elbow dislocation, and then little leaguer elbow, where the apophysis of the medial epicondyle can be chronically avulsed. So this is an example of cubital tunnel syndrome. This is in the left elbow. So we've taken the measurement at the level of the medial epicondyle. We follow the ulnar nerve into the cubital tunnel, and it's markedly hypoechoic and swollen, measuring 0.29 square centimeters as opposed to 0.14 square centimeters. In the long axis, you can see the swelling of the ulnar nerve, and then the resumption of normal nerve size within the forearm. This is another example of cubital tunnel syndrome. So we have the ulnar nerve hypoechoic and swollen within the cubital tunnel. In comparison to the right asymptomatic side, there is enlargement, and we can see the focal enlargement of the ulnar nerve as it passes through the cubital tunnel. This is an example of an Ecodius epitrochlearis muscle, so we have this accessory muscle within the cubital tunnel. Ulnar nerve instability refers to subluxation or dislocation of the ulnar nerve during elbow flexion. It can be caused by congenital, partial, or complete absence of the cubital tunnel retinaculum. That's another name for the arcuate ligament. What happens is that the ulnar nerve subluxates over the tip of the epicondyle, and in some patients will also dislocate anterior to the epicondyle. The patient will report a transient snapping sensation during flexion of the elbow. In asymptomatic healthy people, this is a normal variant, and it can be bilateral in 3/4 of cases. In patients with symptoms, though, the repetitive dislocation can cause friction neuropathy. The treatment is surgical transposition of the ulnar nerve in order to avoid more serious damage. So with dynamic ultrasound scanning, what we're looking for is whether the ulnar nerve subluxates or dislocates anterior to the medial epicondyle. With subluxation, the nerve moves out of normal position from the cubital tunnel, but there's no anterior dislocation in front of the medial epicondyle. With a dislocation, you have a complete motion of the ulnar nerve out of the normal groove in the cubital tunnel. In order to allow for maximal subluxation or dislocation, you should avoid pressing too hard with the transducer because the pressure could prevent the nerve from dislocating. This is an example of an ulnar nerve dislocation. So in the neutral position, we have the ulnar nerve posterior to the medial epicondyle with terminal elbow flexion. We see the ulnar nerve far anterior to the medial epicondyle. So this, and it should have been in this location, so it's moved out of position anteriorly. Snapping tricep syndrome can also occur during elbow flexion, and it represents dislocation of the medial head triceps muscle anterior to the medial epicondyle. It occurs after the ulnar nerve dislocates. So the patient will report, instead of just one snap during elbow flexion, 2 palpable snaps. The first snap being the ulnar nerve dislocating, and the second snap being the medial triceps subluxating. Clinically, the patient will have medial elbow pain, the snapping sensation, and ulnar neuropathy. Proposed causes for snapping triceps are a hypertrophied triceps muscle, accessory triceps tendon, an abnormal medial head triceps muscle, or post-traumatic osseous abnormalities. It's important to differentiate between snapping triceps syndrome and ulnar nerve dislocation because the surgical treatment is different for each condition. So this is a graphic depicting what happens in snapping triceps syndrome. So in the neutral position, the ulnar nerve remains posterior to the medial epicondyle. With elbow flexion, the ulnar nerve first dislocates over the medial epicondyle, followed by medial head of the triceps subluxation. So this video shows what happens in snapping triceps. So what we have first, I'll let it replay, then we can take a look at it. So first the ulnar nerve dislocates, and then the medial triceps gradually subluxates over the medial epicondyle with further flexion. So that's a snapping triceps syndrome. This is another snapping triceps syndrome. So we have the ulnar nerve in normal position in neutral, and then with elbow flexion, we have the ulnar nerve dislocate followed by medial triceps muscle dislocating over the medial epicondyle. So the median nerve can be compressed in the elbow at 4 potential sites. The first is at the supracondylar process and ligament of Struthers, which is a variable in presentation. This is a congenital abnormality to have a supracondylar process, but it's easily ascertained by imaging the median nerve in this location. Next, it can become compressed between the ulnar and the humeral heads of the pronator teres muscle. Third, at the lacertus fibrosus of the biceps tendon, so otherwise this is known as the biceps aponeurosis. And the fourth potential site of compression is at the fibrous edge of the flexor digitorum superficialis muscle. So we'll look at each of these individually. So this is on ultrasound where we would expect to have a supracondylar process and ligament of Struthers. This patient does not have one, but basically the median nerve runs very close to the humerus in this location, so you can imagine any kind of supracondylar process could impinge upon the nerve in that location. This is where the median nerve passes between the humeral head of the pronator teres and the ulnar head, so we have the median nerve between them. We have a couple of images showing that relationship. So the arrow is pointing to the median nerve and between the humeral head and ulnar head. The median nerve continues to pass in this direction between the two heads. It becomes a little bit flat in most patients in this location. You're looking for enlargement or swelling proximal to where it goes through the pronator teres. And here it is in the long axis, passing through the ulnar and humeral head. This location of compression has a name, pronator syndrome, and the symptoms will be numbness in the median nerve distribution when the patient repetitively pronates or supinates the forearm. On physical examination, resistance to pronation elicits pain in the forearm, so that helps with diagnosis. So again, it would be compression between the two heads of the pronator teres, causing pronator syndrome. Next, there can be potential compression at the lacertus fibrosus. So the lacertus fibrosus represents this thin band of tissue that runs from the distal biceps tendon across the arm and over to the ulna. It crosses over the median nerve, so the median nerve could potentially be compressed by it. And then the last site of potential compression is at the flexor digitorum superficialis muscle, fibrous edge. So this is the flexor digitorum superficialis muscle, and the median nerve passes just adjacent to that. So now I'm going to talk about the radial nerve. So the radial nerve splits into the superficial radial nerve at the level just below the radiocapitellar joint, and the posterior interosseous nerve, which enters the supinator just below the level of the elbow joint. The PIN courses between the deep and superficial heads of the supinator muscle before emerging from the supinator muscle in a more posterior location, and then it runs along the interosseous membrane. So this is the deep head of the supinator, and this is the superficial head of the supinator muscle. So the potential sites of compression of the posterior interosseous nerve are multiple. We can't see all of these on ultrasound. The major one that we can see on ultrasound is at the proximal edge of the supinator and at the distal end of the supinator. One cause are fibrous bands extending from the radiocapitellar joint that would not be visible with ultrasound. At the tendinous edge of the extensor carpi radialis brevis muscle, there can be compression. That might be suggested with ultrasound. There's something called the leash of Henry, which means that there's numerous branches of the radial recurrent artery that compress the posterior interosseous nerve. That we can suggest the possibility of with ultrasound, but it's difficult to determine. And then the arcade of Froese at the proximal edge of the supinator muscle is the site that we typically are going to look for PIN compression. It's the most common location. And at the distal end of the supinator, there can be a fibrous band. So this is the posterior interosseous nerve and long axis. We're following it at the level of the radiocapitellar joint. And then this is where it would be at the tendinous edge of the extensor carpi radialis brevis. Now we're following it to the supinator muscle entrance. So it's in this location. So we follow it into the supinator. It becomes more flattened, and that's true in normal individuals who are asymptomatic as well. And then you can follow it all the way to the distal end of the supinator. The radial nerve can be affected by two types of compressive syndromes. One is called radial tunnel syndrome, and the other is called posterior interosseous nerve syndrome. Both of these syndromes are actually caused by PIN compression within the radial tunnel. With radial tunnel syndrome, there's pain but no motor deficit, whereas in PIN syndrome, it's purely a motor deficit in the muscles supplied by the PIN without any pain. Both of these entities can coexist with lateral epicondylitis, so it's important to always include in your examination visualization of the radiocapitellar joint for any joint disease that might be causing pain, and then imaging the lateral epicondyle and the common extensor tendon for any tears. So this is the PIN within the supinator again. So this was a case of bilateral PIN enlargement at the arcade of Frosch at the entrance to the supinator. So first we'll look at the right side. So the right side is enlarged. We've lost vesicular architecture. We get a cross-sectional area measurement. You can also measure the AP dimension. That's been cited in the literature. And then at the supinator muscle, we can see that it becomes more flat, and the long axis image demonstrates the enlargement with the progressive narrowing of the nerve at the supinator muscle entrance. In this patient's left arm, we found similar findings, and mind you, they were having symptoms typical of PIN syndrome. So an enlarged posterior interosseous nerve at the entrance to the supinator. Then on long axis imaging, we see this progressive narrowing of the nerve as it crosses through the supinator. So now let's look at the median and ulnar nerve in the wrist and hand. The median nerve, as we talked about earlier, supplies sensory innervation to the thumb through ring fingers, and at the ring finger, it's the radial half of the ring finger. It also supplies motor innervation to the thenar muscles. The ulnar nerve supplies sensory to the ulnar half of the ring finger, so the other side of the ring finger. So we're talking about this side here, whereas the median nerve supplies the radial side, and it supplies the small finger. It supplies motor to the hypothenar muscles. So the hypothenar muscles are on this side of the hand, the thenar muscles are on this side of the hand. We review all of those in the wrist and hand anatomy module. So the proximal carpal tunnel, we can show the anatomy and the relationships on ultrasound. So the carpal tunnel is formed on its floor by the carpal bones. So in the proximal tunnel, it's the scaphoid, lunate, triquetrum, and pisiform. And then the roof of the carpal tunnel is the flexor retinaculum, this ligament right here. And within the carpal tunnel, we have the flexor digitorum superficialis and flexor digitorum profundus tendons, as well as the flexor pollicis longus tendon. And then the median nerve lies just superficial to the FDS tendon. So on the corresponding ultrasound image, we can see the flexor retinaculum right here, scaphoid bone, pisiform bone, median nerve, and then approximately here we have the flexor digitorum superficialis. Here's the FPL tendon and the flexor digitorum profundus tendon. Within the distal tunnel, it's the distal carpal row that forms the floor of the tunnel. So we have the hamate, the capitate, the trapezoid, and the trapezium. The flexor retinaculum runs from the hook of the hamate to the trapezium, and then the median nerve lies between the FPL and the FDS tendons, and the FDP tendons are in the similar location. So in the corresponding ultrasound image, which is the mirror image of this graphic, we have the trapezium on the left, and connecting to the hook of the hamate by means of the transverse carpal ligament or flexor retinaculum. The median nerve is located closer to the trapezial side, flexor digitorum tendons, and then flexor pollicis longus tendon is over here. So in carpal tunnel syndrome, what occurs is that there's compression within the carpal tunnel at the flexor retinaculum or transverse carpal ligament, and then the nerve becomes swollen just proximal to it. This abrupt change in caliber of the nerve as it enters the carpal tunnel is called the notch sign. The echotextural changes in the compressed nerve are typical of what we've seen in other nerves, so we get decreased echogenicity and loss of the fascicular pattern. So this is an example of severe bilateral carpal tunnel syndrome. Scanning at the carpal tunnel inlet just before the nerve enters the tunnel, we have a severely enlarged median nerve measuring 0.30 square centimeters with loss of fascicular architecture and decreased echogenicity. Image obtained of the median nerve at the pronator quadratus demonstrates a nerve size markedly smaller with preserved fascicles. So we talk about this in much more detail in the wrist pathology module, but the way to diagnose carpal tunnel syndrome is by taking a comparison of the size of the median nerve at the carpal tunnel inlet to the size of the median nerve at the pronator quadratus. And if you want to learn more about the details of how to do this, you should look at the wrist pathology lecture. In this patient in the long axis, we can see the notch sign. So here's the swollen median nerve entering the carpal tunnel and getting narrow as it enters the carpal tunnel. This was the other wrist. So we see the normal architecture preserved at the pronator quadratus. And then at the carpal tunnel inlet, a markedly enlarged hypoechoic nerve with loss of fascicular architecture. And then this is in the long axis, the swollen nerve. So for classifying abnormalities of the ulnar nerve at the wrist when it courses through Guillon's canal, we divide the ulnar nerve into 3 zones at the potential sites of compression. So zone 1 extends from the proximal edge of the palmar carpal ligament to the bifurcation of the ulnar nerve into the deep motor and sensory branches. So this runs along the inner aspect of the pisiform to about the level of the hook of the hamate. Then zone 2 extends to the from the bifurcation just distal to the fibrous arch of the hypothenar muscles and contains the deep motor branch of the ulnar nerve. Zone 3 runs parallel to zone 2 and contains the sensory branch running from the bifurcation through to the ulnar aspect of the palm. So by knowing the zone of potential compression, you can understand what parts of the ulnar nerve might be affected. So compression in zone 1 would indicate that there would be a sensory and motor deficit of the ulnar nerve, whereas compression in zone 2 would indicate that there's a motor deficit by itself without any sensory deficit, and then compression of zone 3, where the superficial branch runs, would only involve sensory deficit without motor deficit. So this is the ulnar nerve within Guillon's canal, and you can see it's along the inner aspect of the pisiform with the ulnar artery adjacent to it. You can follow it all the way through Guillon's canal. The arrow is pointing to the nerve. Right at the level of the hook of the hamate, it divides into the deep motor and superficial sensory branches. And then you can see it running along the hypothenar muscles. This is the motor branch along the hypothenar muscles. And then this is the sensory branch near the Guillon's canal in zone 3. This is an example on MRI of an ulnar neuropathy caused by a Guillaume's canal abnormality. We don't have corresponding ultrasound images, but it's useful just to show this case to get a sense of what you might see on ultrasound. So this was a large ganglion cyst from the pisiform triquetral joint. On the short axis images, you can see the ulnar nerve is increased in signal intensity, which is similar to ultrasound, where the nerve will be hypoechoic and swollen. It's also increased in size. As we follow the nerve distally, you could see that it's basically completely compressed by this large ganglion cyst. So that's an ulnar neuropathy with denervation. And then the denervation we saw within the hypothenar muscles. So notice the streaks of high signal that represents fat, and the decrease in volume as compared with the thenar muscles. Notice the much larger volume of the muscles with none of that fatty streaking. So there's atrophy of the hypothenar muscles from the denervation. Superficial radial nerve syndrome is caused by entrapment of the sensory branch of the radial nerve in the distal forearm. It courses in a superficial subcutaneous plane to provide sensory innervation to the radial half of the hand, which we've gone over before. Basically the thumb through the radial aspect of the ring finger. The potential sites of compression are fascial bands at the nerve's exit point in the subcutaneous plane, the brachioradialis tendon, the extensor carpi ulnaris tendon, and the ganglion cysts arising from the radiocarpal joint. It's also can be injured during venipuncture because of its location adjacent to the cephalic vein. So this is the superficial branch of the radial nerve running along the distal radius. It's in the subcutaneous fatty plane at this point, so it's right here where the arrow is pointing. And then we can see it in the long axis as well along the distal radius. Thank you very much for your attention. This concludes the upper extremity nerve anatomy and pathology module.